All right. That many of the recommendations for screening and treatment with VTE in pregnancy are based on largely expert opinion, and there's not a lot of data. And it's funny, as we cover different topics, Donna and I often say that there's so much that we do that is based on observational information and very little data. We put our heads together and come up with the best approaches. And that's not always great, but I think it does allow us to change our management in these situations to the best for our particular patient population. So we're talking about this from the standpoint of what we deal with here in our state, which is very similar across the Southeast and in the US. The learning objectives: why does pregnancy increase the risk for VTE? When is the risk greatest in pregnancy? What are the risk factors, particularly the two most commonly or two most important risk factors that we see? And then what's the best way to assess which patients really need thromboprophylaxis? Next slide. So we always talk about our pregnancy-related mortality, and here in the US, the last data that we have on this is from 2013. And if you look at the fourth group of graphs here, thrombotic pulmonary embolism, you can see accounts for a major proportion of our maternal mortality in the United States. Next slide. So this is old data, and I always will point that out, that it's from 2013, and that's probably different today than it was then. We know that there's a 5-fold increased risk of pregnancy and postpartum related VTE, but the overall incidence is 1 to 2 per thousand. So that doesn't sound like a lot, but truly when you're reviewing our patients with mortality, it ends up being a lot. Again, it accounts for 10% of the maternal mortality in the US. Interestingly, the World Health Organization did a systematic review back in I believe it was 2015, and showed that 15% of maternal mortality in high resource countries was associated with pulmonary embolism. And those countries included the European countries, Japan, North America, Australia, and New Zealand. So not the third world countries. We're talking about countries that include Canada and the US of A. But in the UK, their review of maternal deaths, they go through this confidential inquiry committee where they look at their maternal mortality. And their review in 2003 to 2005 showed that 31% of their maternal deaths were directly related to pulmonary or VTE during pregnancy. And that led them to implement some strategies that we'll talk about today. DVT accounts for 75 to 80% of the thrombosis that we see. Pulmonary embolism accounts for 20 to 25% of the VTE. Half of those clots occur during pregnancy. The other half occur after delivery. And the risk per day for VTE is highest at 2 to 3 weeks postpartum. So it increases as pregnancy progresses. It's lowest in the first trimester, but it increases steadily and significantly after 12 weeks of pregnancy. Next slide. So the risk of VTE, the reason that we see an increased risk, are due to physical as well as physiologic changes. The physical changes have to do with compression of the inferior vena cava and the pelvic veins from the growing uterus. The hormonal changes also lead to venous dilatation and lead to increased stasis and increased risk for clot. We know that pregnant moms are not as mobile as they are when they're not pregnant. And as pregnancy progresses, they are less and less mobile, and that contributes to this risk. And then hypercoagulability is a known risk associated with pregnancy, most commonly believed to be due to the changes in the coagulation factors associated with hormonal changes. Next slide. And this is a slide that you learn from medical school and residency, and you don't have to know it all, but just to understand that a majority of the procoagulants, the things in our blood that lead to blood clots, those factors are increased in the pregnancy, thus increasing the risk of clots. Next slide. So given, though, the overall low absolute risk for clots, we've got to come up with a way to stratify risk to decide, well, how are we going to know which patients we need to prophylax during pregnancy and in the postpartum state? It's one of those situations where, yeah, why don't we just treat everybody with Lovenox to prophylax against VTE? The problem with that is cost and side effects. And the intervention requires a needle, and many patients are not compliant when they need to be compliant. So we need to stratify which patients would benefit the most. Understanding also that the threshold for thromboprophylaxis recommendation is lower in the postpartum state due to the higher risk per day of clots and the shorter duration of that risk. So when you talk about giving a patient a medicine like Lovenox throughout the pregnancy for 28 to 40 weeks, that's a lot different than saying, Ms. Jones, we want you to take this for the next 4 weeks. They're a lot more likely to buy into that, and the risk benefit is definitely there for that. Next slide. So risk factors, and you can find these all throughout the literature, and different people say different things, but this is a conglomeration from ACOG as well as the Royal College of OBGYN and several studies thrown in. But we know that the most common risk factor for the highest risk of VTE is a prior blood clot with a 2 to 11% recurrence risk and an adjusted odds ratio of almost 25. So that's very significant. The next most important or common is inherited thrombophilias. And these are found in 20 to 50% of pregnancy-related clots. The adjusted odds ratio really depends on the specific thrombophilia. So the high-risk thrombophilia have a much higher incidence. Let's say the antithrombin mutation has an adjusted odds ratio as high as 50. The antiphospholipid antibody syndrome has an adjusted odds ratio of about 13. ACOG has a nice table that kind of summarizes this in their bulletin 196. One of the risk factors that we're seeing increasing, we talk about it almost every echo because one of the morbidities that we're discussing is associated with obesity. And obesity is definitely associated with an increasing risk of DVT, and even more so with pulmonary embolism, which is much more significant or worse than the DVT. AMA has a slightly associated risk. Immobility and long travel, we talk about this. I have patients that want to travel during pregnancy, and whether it's flying or driving, I tell them they need to stop and get out and walk every 2 hours or get up out of their plane seat every 2 hours. But it's been shown that 4 hours or more of immobility increases the odds of a clot by 7.7 to 10.8 times. So that is significant. Other risk factors: hospital admission, smoking, any type of hypertension, sickle cell anemia, multiple gestations, C-sections we'll talk about a little bit later, particularly if you see C-sections following labor with chorioamnionitis and postpartum hemorrhage. Next slide. So how do we come up with some way to stratify that risk? So we know what the risk factors are. So do you put everybody on blood thinner or mechanical devices if they have a single risk factor? And nobody has really agreed on that. Different groups say different things. ACOG and American College of Chest Physicians probably are the least aggressive. But I mentioned earlier how high the incidence of maternal mortality was in the UK. In 2005, they came up with a very aggressive protocol to combat VTE during pregnancy. And they came up with the Royal College scoring system, which is what I really like, this scoring system, and use it daily. And I'm not advocating that you have to use this system, but it certainly is a very nicely defined and well delineated system to determine what patients you need to intervene for. And I'll give you which patients that we need to intervene for in a slide or two from this. But these are the risk factors and the point system. If they've had and I'm going to run through this briefly because I think it's important to understand how this works. If a patient has had a previous VTE except a single event related to major surgery, that patient would get a 4-point score. If they have ovarian hyperstimulation, they would get 4 points. If they would be assigned 2 points. If they're obese over 40 BMI, they would get 2 points. So if they had both of those, they would get 4 points. Then down to the next category, a previous VTE provoked by major surgery, they would get 3 points. A known high-risk thrombophilia, any surgical procedure like appendectomy or postpartum tubal, they would, which is interesting, but I think that's more associated with the immobility that many of these people experience. In the medical comorbidities such as lupus, inflammatory bowel disease, remember nephrotic syndrome, and it doesn't even have to be true nephrotic syndrome, but if a patient has an elevated protein spill, they lose that protein S and protein C and become deficient. Those patients can have a significantly increased risk of a clot. Sickle cell anemia is something we see a lot here in South Carolina, and current drug users. Any of these comorbidities would be assigned 3 points. And then this whole myriad of other risk factors, you would get 1 point for each. And that is a family history of a VTE in a first-degree relative, a low-risk thrombophilia with no VTE, age over 35. If they're obese between 30 and 40 BMI, they would get 1 point. 3 or more previous babies, smoker, gross varicosities, preeclampsia, multiples, elective C-section, and so forth. It's all outlined very well. So I really have this chart up in my office, and I refer to it, my nurses refer to it, and it helps us determine what patients we need to pay particular attention to and counsel them about VTE risk. Next slide. So just a quick review about the high-risk thrombophilias, and we'll talk about this more in future discussions, but factor V latent mutation, homozygosity, the prothrombin gene, homozygosity, and if they are heterozygous for both of those together, that's a high-risk thrombophilia, antithrombin deficiency. So any of those patients would get that high-risk score. Next slide. So this is what you do with the scoring system. If they have a score of 4 or more antenatal, thromboprophylaxis should be recommended from the first trimester on. If they have a score of 3 or less, 3, then you would consider thromboprophylaxis from 28 weeks. Again, because that risk of clotting increases as they go along in the pregnancy. If they have a score of 2 or more after delivery, consider thromboprophylaxis for at least 10 days. Now, this is where we differ a little bit from the Royal College. We typically will go 4 to 6 weeks postnatally. But again, this is from their guidelines. If the patient is admitted to the hospital antenatally for an antepartum complication, whether it be preterm labor, preeclampsia, hyperemesis, whatever, at least consider some form of thromboprophylaxis. That could be mechanical versus medical management. And if a patient has a prolonged admission, this is something that we've really changed in our house here. Or if a patient has readmission during the puerperum, consider thromboprophylaxis, and we will very frequently in these patients use medical thromboprophylaxis. Next slide. So while we all know that pre-pregnancy counseling, preconception counseling would be really nice, the fact is we don't get to see these patients preconceptually very often. And because first trimester VTE risk is really a significant issue, I think it's important to make the statement that we need to talk to these patients at the time of delivery and at their postpartum visit on what we need to do in their next pregnancies as well. We need to assess their risk factors at their very first visit, look at preventive interventions, talk about it with the patient, talk to them about the risk, and understand that interventions prenatally or antenatally can really be an opportunity to impact the outcomes of these patients in the future. Thromboprophylaxis is the most implementable way of reducing mortality from thromboembolism. It's an area that we really can make a huge impact in improving our mortality statistics in this country. The adoption of this particular protocol and aggressive thromboprophylaxis in the United Kingdom has really paid big dividends and lowered their deaths from VTE significantly since they enacted that in 2005. And it's just like the CMQCC, the bundles that we see that have helped lower the maternal mortality rate in California. This is just a small piece of the puzzle that I think that can make a huge difference. So let's just go through a few questions and then I'll stop and open it up for questions. Pregnancy increases the risk of VTE due to mechanical compression, estrogen increases, impaired mobility, or all the above. Use the chat and let me see what everybody says. You know, when I used to make questions for the National Board of Medical Examiners, they would never let us use all the above because it usually gives it away. But that's it, and everybody's choosing D. And it is all of the above. Next slide. The risk factor with the greatest risk of VTE in pregnancy. Everybody enter the chat which your answer is here. Again, same question, same answer, number D. All of these increase the risk of VTE in pregnancy, but the one with the greatest risk is prior VTE, and the next is the high-risk thrombophilias in pregnancy. So I think we've answered most of these questions with the exception of the last one. And I put that question in the learning objectives, because I think it's very important for us to come up with individual ways that are going to be best for our particular practice of how to screen and how to decide what patients need medical thromboprophylaxis. It's one of the areas that we have had a huge in the department discussion with here at Prisma Midlands at USC. Will frequently disagree. We disagree even more when we talk about dosing for thromboprophylaxis, and that's why that will be a topic of discussion next time. It requires a lot more discussion and interaction, so that'll be a little bit more difficult to echo, but I really hope you come in 2 weeks prepared to discuss, ask questions, and we'll try to give some cases to help come up with ways that we choose to intervene for our patients with medical thromboprophylaxis. Next slide. So in the future discussion, we're going to talk about the types of thromboprophylaxis and dosing strategies. That's going to be the really big focus next time. The time after that, we're going to talk about using safety bundles and the proposed safety bundle from SMFM, ACOG, and other societies in trying to prevent and decrease VTE in pregnancy and thus improve our maternal outcomes and decrease maternal mortality. And again, this is just an area that I think is something that we can make a huge difference in our patient population. If there's ever a spot that we can lower maternal mortality, and this is the etiology that we can have the biggest impact. The last thing I will say is I think it's important to understand that even though our stated incidence of VTE as etiology of maternal mortality in the US was 9.3%, I think, back in 2013. All of the risk factors and comorbidities that are associated with VTE have increased in incidence over the last 10 years. So I cannot help but think that over the last 10 years, our rate of the impact of VTE on maternal mortality has increased. So please, I'm going to stop and ask for